honor to be speaking to such a distinguished group of urologists. Today, I will be discussing two topics. First will be the PCNL during COVID, and next will be about mini PCNL. I'm sure a lot of you already know the general principles involved in doing a PCNL, but I hope you can still pick up some practical tips from this lecture. I would like to acknowledge the endourology experts among the ranks of PUA Mindanao, notably Dr. Kix Latayan and Doc Chico Lu. Good morning. So this topic will be about the important factors that are needed to be considered on doing surgery during this time of pandemic. Disclaimer lang, I don't claim to be an expert on this subject matter, as I think anybody really is, since this is all new. I hope this can help set recommendations on restarting surgery in your area. So before the COVID-19, PCNL in the Philippines was undergoing a revolution. The procedure was being quickly adopted by most urologists. All training institutions became adept in doing PCNL. Many different techniques were being introduced, such as the supine PCNL, and the miniaturization techniques were being introduced, such as your SMP and UMP. PCNL was quickly becoming the procedure of choice for most urologists when dealing with renal stones and proximal ureteral stones. But then, as you all know, everything changed when the pandemic hit. All elective surgeries came to a halt. During the pandemic, it is recommended to limit all elective procedures. Number one, to reduce the burden on healthcare and to decrease foot traffic to minimize contagion risk. These are the recommendations of EAU Urolithiasis Guidelines Panel regarding treatment of urolithiasis cases. And these are categorized into low priority up to emergency cases. The categories are based on clinical harm if procedure is postponed. Sepsis due to obstructing stones, anuria, and renal insufficiency due to bilateral obstruction or a solitary kidney is considered an emergency and warrants urgent decompression. With regards to renal stones, these are the recommendations. As you can see, renal stones with recurrent infection and obstruction, partial or complete staghorn, fall under the high priority column, which means clinical harm is likely if it is postponed for more than 6 weeks. Decompression should be the initial treatment. But the guidelines also state that we should do interventional stone removal as early as possible. So, sooner or later, we will have to do PCNL during this time of pandemic. The question is, when is the correct timing for these surgeries, and what can we do to make our surgeries safe? I'm going to discuss the EAU recommendations for surgery. These may be a bit tedious, but these guidelines are the foundation by which further recommendations will be based upon. These were taken from the EAU, discussed by the EAU GORGG, which is the Rapid Reaction Group. It is important to note that these recommendations might still change in the coming weeks as the situation progresses. So the disclaimer states that the recommendations are geared to help healthcare systems which are severely constrained. The situation in our local setting may be different, so some of these recommendations may not apply to our local settings. For the general recommendations, first is depending on resources and capacity, we recommend treating only high priority and emergency cases during the COVID pandemic. Next is to not only consider the equipment or an ICU bed capacity, but also the availability of blood and drugs in order to prioritize which types of surgeries will be done first. We also have to know that even low priority patients will increase the footfall and thus the risk of COVID transmission between patients and staff. Consider that surgery has been reported to be harmful in asymptomatic patients who subsequently tested COVID positive. You may consider treating intermediate priority patients if capacity is available, but definitely not during a COVID surge. You also have to consider older patients with a comorbidity who are at a severe risk for COVID infection and fatal outcomes. So you have to carefully balance if in high priority cases, surgery is the only alternative. Where ventilator capacity for COVID has, okay, this isn't really on us because definitely in your area there has been a surge, right? But nevertheless, high priority surgical candidates requiring ICU ventilation should be triaged. Okay, following the local recommendations to test staff and patients for COVID, if resources are available. These may differ per hospital and country, so you need to be familiar with the local guidelines set by the local health authorities. Following the recommendations, if available, full PPE should be worn during operations, irrespective of COVID status of the patient. We also have to wear full PPEs, of course, for COVID positive patients. Intubation and extubation preferably should take place in a negative pressure room if it is available. All non-essential staff should stay outside the operating room during the procedure. Uh, Set electrocautery units to the lowest possible setting, and avoid the use of monopolar, ultrasonic dissectors, and bipolar devices because these can lead to particle aerosolization. If available, smoke evacuator should be used, and definitely clean surgical equipment of COVID positive or suspected patients separately. So in doing PCNL during these times, the safety of healthcare staff and the patient should be the first priority. It is important to know what factors can make us at risk of contracting the virus. So COVID-19 will not go away anytime soon. More and more patients will require different types of surgery, PCNL included. The goal then is to make the procedure as safe as possible for both patients and healthcare workers. This is also lifted from EAU. So to minimize the risk, it is recommended that all procedures should be performed by experienced urologists, confident in the procedure. They should be performed with minimum number of staff members. Furthermore, no external observers should be present during the procedures. I added this, avoid contamination with the irrigating fluid, as this can be, well, it's not yet proven, but this may be a source of contamination. But of course, the protocols for resumption of elective surgeries will be different for every locality and should be determined by the local hospital together with the local health authorities. In doing surgeries, preoperative investigation is needed to protect both patient and healthcare staff. It is now recommended to do RT-PCR testing for all elective surgery cases. This is the stand of all subspecialty societies in the Philippines as of the moment. A chest CT scan may be used as an adjunct to the use of RT-PCR to increase detection rates. A stringent screening of patients is most important, especially knowing whether a patient had been in contact with any COVID-19 confirmed, probable, or suspect in the community because of the reported high morbidity and mortality in a subset of asymptomatic patients who were operated during their incubation period. Again, proper PPEs should be used, and more importantly, the surgeons need to learn how to properly don and properly doff these PPEs. So what are some of the factors that affect the safety of the operation? The general anesthesia is always a risk. The viral load in the irrigating fluid, availability of proper PPEs, and the sterilization of the OR room after the surgery. For general anesthesia, the problem is that in general anesthesia is an aerosolizing procedure. So aerosol generating procedures, which include intubation, non-invasive ventilation, tracheotomy, CPR, as well as manual ventilation prior to intubation, and bronchoscopy are associated with increased risk of COVID transmission. The goals for infection control during anesthesia include prevention of transmission of infection to care providers and prevention of contamination of anesthesia machine and other equipment. For this, there have been new anesthesia guidelines that have been developed to maximize safety of hospital staff during GA procedures, such as the use of aerosol boxes during the preparation phase, the avoidance of high flow pre-oxygenation during the oxygenation phase, and the use of video laryngoscope and rapid sequence induction during the intubation phase. For the irrigating fluid, should we be worried about contamination from the irrigation fluid used when doing a PCNL? What is in it? Basically, it's plain NSS, urine, and blood. To know the risk, we must know the viral loads of each component. In my search for literature regarding this, I have found two journals discussing this topic. First is a research letter from JAMA by Wang et al., which showed that out of 300 samples taken from blood, only 3 specimens were positive for viral load on RT-PCR. None of the 72 urine samples turned out positive. It is also very important to note that fecal samples turned out positive 29% of the time, and that live virus was detected in feces, implying that SARS-CoV-2 may be transmitted by fecal route. Since our cystoscopic procedures are in close proximity to the anus, we have to be very careful. The next study, which was also cited by the EAU, proves that viral nucleic acid can also be found in the urine, as opposed to the last study. The study was done on 66 convalescent patients. It is important to note that viral RNA was present in urine after throat swabs were negative. So the viral nucleic acid was found in urine in only 4 patients out of 58 cases. Meron pa rin. Okay, even if it's only 4. To note is 14 serum specimens, none showed a positive result. Although relevant, this data does not correlate or prove a link between urine spillage and virus transmission. Although no evidence of disease transmission through urine is yet to be demonstrated yet, urine sampling, for example, for urine culture, dipsticks, and analysis, urethral catheterization, and endoscopic procedures such as your TURP, TURBT, or ureteral stenting should be executed with caution. During the ORs, spills are inevitable. Surfaces should be rapidly cleaned by using appropriate absorbent and decontaminated with chlorine or another appropriate disinfectant. Sorry, meron akong invaders dito sa kwarto. Wait lang. Wait lang. Okay na. So, what if you do surgery and after the surgery, your patient develops symptoms and turns out to be COVID positive? This study in China, done in China, reports the clinical characteristics and outcomes of COVID positive patients who underwent surgeries during the incubation period of the virus. So, there were 34 operative patients with a median age of 55. Excuse me, wait lang. Sorry for that. Work from home situation ng mga ano. Okay, so out of the 34 operative patients with a median age of 55, 20 patients were women. All patients developed COVID-19 pneumonia. So all 34 patients developed pneumonia shortly after surgery with abnormal findings on chest CT scans. Common symptoms included fever, fatigue, and dry cough. 15 patients required admission to the ICU during disease progression, and 7 patients died after admission to the ICU. So that's 7 out of 34. Compared to the non-ICU patients, ICU patients were older and were more likely to have underlying comorbidities. The patient who died underwent more difficult surgeries, as well as had more severe laboratory abnormalities. The most common complication in non-survivors included ARDS, shock, arrhythmia, and acute cardiac injury. So I cannot understate the value of testing before any elective surgery. If patient turns out to be uh, COVID positive, it may spell out disaster for both you and the patient. So defer the planned elective surgery until patient becomes COVID negative. This is due to the reported high morbidity and mortality rates in patients undergoing surgery during the incubation period. So in summary, COVID-19 will not go away anytime soon. The recommendations may serve as a guide, but ultimately the decision to start performing surgeries such as PCNL will depend on local policies together with health authorities. During an operation, we have to be mindful of the factors that may predispose the patient or staff to infection, like the anesthesia, the viral load in the irrigating fluid, and proper donning and doffing techniques. The first surgery if patient turns out to be COVID positive because they are more at risk for morbidity and mortality. Proper and rational use of PPEs coupled with proper donning and doffing techniques should always be observed. PCNL may be done once proper protocols have been set by local hospitals in conjunction with health authorities. So more and more patients will require different types of surgery, this PCNL included. We should always remember that in this pandemic, each area experiences things very differently. So we need to adapt to what we have, and we need to be safe, keep safe, and also be very informed. Also, we have to remember in regards to PCNL that PCNL is never an emergency procedure. Okay, we have to always keep the safety of the healthcare workers and the patients as the foremost priority. Thank you.
Okay, thank you, JM, for a very informative lecture. Rod, so what do you, can we go straight to the discussion right now, or we go to the second lecture?
Second lecture na lang, JM, no? And then Q&A.
Okay,
Before
sir.
the reaction of the panel reactors.
Yes.
Okay, sir.
Okay.
So this is very general and a few tips and tricks. I know a lot of you already know this. I hope you can pick up some things that you will learn in this lecture. So mini PCNL was first described by Jackman et al., wherein he described a percutaneous access to the kidney using a ureteroscopy sheath. In 2001, Lamy et al. Described a standard mini-PERC, wherein he introduced standardized instruments in doing a mini PCNL. This is the Wolf system. Since then, miniaturization has been essential to the development of new technologies in PCNL. MicroPERC SMP and UMP has been created with sizes ranging from French 8 to French 20. In mini PCNL, irrigation pressure is used to aid in evacuating stones. This is known as the vacuum cleaner effect or vortex effect. Others use the irrigating channels to flush out stone fragments, and others use irrigating pumps. Some systems developed for mini PCNL are the Chinese mini PCNL, the Storrs mini PERC, and the Wolf mini PERC. These are some of the common mini PCNL systems. This first is the Storrs mini PERC system. The system uses a French 12 nephroscope and a 15, either a 15, a 16.5, or a 21 French sheath. Uh, you can do a single step dilation, and a metal dilator is included in the system. This is the Wolf Mini Perk system, and it uses a French 14 nephroscope and either a French 18 or a French 15 sheath. This system is the system originally described by Lamy in 2001. The Chinese PCNL system was designed and developed by Professor Guo Zheng and is being produced by Hawk. This system is unique for being the only one that uses an active suction and irrigating system, and the only one that uses a collecting bottle for the collection of specimen. Mini PCNL has advantages and disadvantages. The advantages being that there is less blood loss due to a smaller sheath, increased maneuverability, and less post-operative pain and shorter hospital stay. Disadvantages is a longer operative time, especially for larger stones. Preoperative assessment should investigate general medical condition, stone burden, presence of infection, and the anatomy of the kidneys, as seen on imaging. The general medical condition pertains to the patient's sex, age, and comorbid conditions such as hypertension, diabetes, CKD, and other lung disease, which will affect the general outcome of the operation. The presence of infection is a contraindication to do PCNL. For patients with no infection, antimicrobial prophylaxis should be administered based on the best practice policy statements on your allergic surgery or the local antibiogram. For patients with active infection, treatment with or without decompression should be done, and ideally a negative culture should be achieved. Imaging should be, CT scan should be always be done prior to doing a PCNL. And on CT scan, it is important to note the size and configuration of the stone, the presence of obstruction and or hydronephrosis, possible access sites, anatomic variants such as your horseshoe kidneys, and a CT urogram may be requested to delineate the correct calyceal anatomy. So this is important to know the actual stone burden. It is important to note the size of the stone in all three planes. Because when you say a 1 centimeter stone and a 2 centimeter stone, it does not actively reflect the total surface area of the stone. It seems like a very small difference, 1 cm to 2 cm. But in terms of volume, a 2 by 2 by 2 cm stone has 8 times the volume of a 1 by 1 by 1 cm stone. And a 3 by 3 by 3 cm stone has 27 times the volume of a 1 by 1 by 1 cm stone. This translates to a longer the longer time in the lithotripsy of a stone with a difference of 1 or 2 centimeters. So before starting any procedure, it's best to have a checklist of all the materials that will be needed. This is to decrease dead time, like when something is needed and someone has to get it because it's not there yet. The choice of dilators will depend on the availability and familiarity of the surgeon. These are the two most common types of dilators used, the Amplats and the Alken telescoping metal dilators. The guide wires used are integral to the proper performance of a PCNL. Access wires such as your zebra and hydrophilic guide wires make it easier to place a guide wire into the ureters for a more secure dilation. A working wire such as your Benson wires are stiff wires for placement during lithotripsy. It is important to have proper access needles when performing a PCNL. When I was in residency, we would use brachytherapy needles for access. It was a lot harder with these types of needles and prone to error and dislodgement of the needles. So for the intraoperative preparation, we'll be talking about patient positioning, the OR layout, and the... Okay, sorry. For patient positioning, I usually do a prone position. So I I don't know how to do a supine position. I know Dr. Latayan and Dr. Lu have been doing supine PCNL already. Uh, it is important to place pillows or frames to support the thorax. I usually place a bolster in the abdomen to make the kidney more stable when dilating, but different surgeons have different techniques on placing bolsters. There is no correct or wrong operating room layout. It's all a matter of surgeon preference. In this setup, the monitor may be placed on either side of the C-arm, depending on which has a straight line path to the planned access site. Uh, all materials should be prepared, including the telescope and the video system, before you puncture. I cannot stress this enough. I always tell this to the residents. Because if you do a puncture and you dilate and your camera system is not yet ready, while you're preparing the camera, the kidney is bleeding. So when you enter the kidney, it's full of blood clots. So it is essential that after dilation, you get to see the kidney immediately and instill irrigating fluid to minimize the risk of blood clots inside the kidneys. Okay. Puncture will partly depend on the CT scan images, but mostly from the images from intra-op decision making based on the retrograde pyelogram. The first access should be along the tract of maximum stone burden. To check if the needle is inside the collecting system, what I do is I try to infuse, the operative word try to infuse 2 cc of water in a 10 cc syringe. Check for resistance. If there is resistance, you're probably still in the parenchyma. Water may be infused from an open-ended catheter to show egress of water from the puncture needle if you are inside the collecting system. And lastly, dye may be infused to check which calyx was entered. This is to be done if you are already sure that you are in the collecting system. Uh, I also puncture first before I incise the skin. Some urologists incise for the skin first before doing a puncture. They say this is to help the para hindi maluma yung needle. I think I'm not sure, but I do puncture first before and do the incision when I'm sure that I am already in the collecting system, so that the patient will not have additional wounds if ever I decide to move the position of the puncture. For dilation, a screwing motion is needed. I have adapted this technique from Professor Zeng using the screwing motion. Different surgeons have different types of different methods of dilating the kidney. But I do a screwing motion because uh, very minimal force is needed and no downward force is needed in order to dilate the kidneys. In my experience also, it is less traumatic to the kidney and this has less bleeding. When access has been achieved, this is when the real work begins. Okay? A lot of urologists say that after the access, it's over. But I don't believe that that's true. Okay? I believe that the real work only begins when you are inside the kidney. You can always abandon the access, but when you're inside the kidney, you have to be very, very careful because this will spell if your surgery will be a success or not. I will discuss some tips to improve stamina while working and improve lithotripsy. So first, posture. And ito yung mga hindi na discuss ng pag sa international conferences. These are very basic, but I believe that this is very important. Okay? The residents that I've been teaching usually have bad posture. Nakataas yung table, nakataas yung kamay. So, they don't have too much stamina. They can't do long procedures. So, proper posture while doing PCNL will help reduce fatigue, especially during long procedure. It helps to have a straight body with your arms tucked while holding the instruments. The table height should be adjusted to achieve proper posture. Also, elevated platforms may be needed. Proper handling of instruments. You need to find the best ergonomic hand position. Uh, you hold the scope, not the camera. Do not cross hands while using when you're using the lithotriptor or the grasper. Find the hand position where you can both maneuver the scope and control the water at the same time with one hand. As for the guide wire, it is of course best to have it in the ureter, both for dilation and while doing lithotripsy. If you're just beginning, it is best to have a guide wire while working. When possible, secure the guide wire into the ureter, but if the guide wire gets pulled out during lithotripsy, don't panic. Just reinsert the guide wire. After access, the most mistakes and injuries come from lithotripsy. Here are some tips to make lithotripsy a bit safer and easier. So you have to touch the stone with the probe and then fire, but don't push the stone. Sharper stones injure the parenchyma, and sometimes the stone pierces the parenchyma, which makes the kidneys bleed. Always be aware of where the probe or the laser is pointed. Another way to make the surgery safe is to be aware of the total lithotripsy time, the total irrigated fluid. In my practice, I set a limit of 90 minutes or 1 hour and 30 minutes, as, sometimes as much as 2 hours if the stone is very big. But I'm very strict with the total irrigated fluid. I try to limit the total irrigating fluid from 30 to 35 liters. Okay. Lastly, I would like to present a study regarding fluid absorption during PCNL. So this was a study done by Malhora, wherein he monitored the irrigating fluid absorption during PCNL with the use of a 1% ethanol as a marker. So when the irrigant use is less than 10 liters, the total irrigant absorbed is only 161 ml. But above 21 to 30 liters, it's more than a liter. Lithotripsy time was also a significant factor to the amount of irrigant absorbed, with more than 90 minutes associated with more than 1.3 liters of fluid absorbed. Okay. So in summary, there are different systems of mini PCNL. All has its advantages and disadvantages. What is important is to be familiar with all of your instruments, check materials needed prior to puncture, do screwing motion for dilation, observe proper posture and handling of operation, and for lithotripsy, do not push the stone. Keep lithotripsy time and irrigation fluid to a minimum if possible. Thank you.
Okay. Thank you. That we're not only for mini PCNL, but we can apply those things for even for the standard. No?
Yes,
So
sir.
can we have the actors? So how do we start, from the youngest to the most senior, or vice versa?
From the most senior.
Okay, by popular demand.
Narinig ba, Mike? Cakes?
Yes,
Yes.
yes, sir.
Yes, sir.
Okay. Good morning, everyone. It's nice to see everyone here. And JM, thank you for this very informative lecture. I would be reacting with regards to the pre-COVID, during COVID, and post-COVID PCNL, because I actually don't have any experience with mini PCNL. I only do the standard PCNL. So it's true with the advent of COVID, a lot of things has changed. Kasi before, our only concern for PCNL patients was just to make sure that the patient's urine was sterile before we do the procedure. But now there are a lot of things to consider, especially protecting ourselves, the staff, and also our patients from the infection of the virus. So, with regards to this era of COVID pandemic, and when we start doing elective procedures again, actually I was able to do quite a few procedures during this time where we still have COVID. Unfortunately, in our setting here in Cagayan de Oro, we don't have any widespread mass testing for COVID. So what we do is we just make sure that the patient doesn't have the symptoms of COVID through history, and also to make sure that he doesn't have any exposure to any COVID suspects. So first and foremost, I think we should have a strict triage of these patients who are to be scheduled for PCNL. So if we don't have the benefit of testing, the RT-PCR, then we should go back to the triage, which encompasses a full medical history to make sure that the patient doesn't have this COVID based on the history and any exposure. Another thing which I incorporate also in my practice is while we are preparing the patient for PCNL and putting him on the antibiotics, which is culture-specific antibiotic, I also make use of this time to tell the patient to isolate from in preparation for surgery. So that would take around 1 week to 2 weeks isolation prior to his admission into the hospital. So antibiotics, and at the same time tell them to isolate. What else? There is also this, what we call the one patient, one room policy in the hospital, wherein most patients should not be in semi-private rooms or ward rooms to avoid transmission of the virus. And one thing I also have thought about during this time is maybe if we can, in the future, incorporate supine PCNL in our practice, because with supine PCNL, I don't know, I don't have any experience with supine PCNL. Probably we can do away with general anesthesia and make do with a regional anesthesia when we do supine PCNL. I don't know. I would like to ask others here who are doing supine PCNL like Kicks and Vic if this is feasible.
Regarding sa supine PCNL, for regional, sir, no? Spinal yung sinasabi mo.
Yeah. If we can do away with GA. Yeah.
Yes, we did that sa Davao, sir. We tried doing the supine sa regional nga, sir, or naka-epidural para medyo kung matagalan, at least you can just give. Kaya lang, it depends on your anesthesiologist. May mga anesthesiologist na medyo kabado rin for regional, kahit na nakasupine. They prefer ng GA. But siguro practice lang din, sir, kung medyo comfortable na kayo with the surgeon and the anesthesiologist, you can develop the technique naman talaga to do away with the GA, sir. X.
Yeah, actually, when we did the PCNL with the regional anesthesia, the only problem that we encountered was yung pag kunyari nagising yung patient, minsan nagagalaw yung position. For supine, you have to keep the patient very still. Unlike pag naka-prone, automatic naka-GA man yun. So, very stable yung position. The only problem we encountered with the regional is kapag nagising yung patient. Although there are some steps like to secure the patient with tape and straps, still pwede pa rin siyang gumalaw. That's the only disadvantage of the regional. But otherwise, it also would depend on the expertise of your anesthesiologist, kung comfortable with the regional plus sedation. So I think that will be a good option. I have a question for JM before I go to Dr. Lu. Regarding yung sa limiting time and fluid amount to 30 to 35. So, do you have a specific stone size of the stone for you to say that, okay, I can do this in 90 minutes to or so and limit my fluid amount to 30 to 35 liters?
Well, there's really no hard and fast rule, sir. But basically, stones more than 3.5 to 4 centimeters, mga 4 by 4 by 4 siya. Mahirap gawin yun, sir, na mahirap gawin within that period. Okay, it will also depend on the hardness of the stone, because lithotripsy's time will
Salamat.
depend. The time of lithotripsy will also depend on the hardness of the stone. Also based on my experience, sir, hindi ganun kadalas nagko-correlate yung house-filled unit with the hardness of the stone. Sometimes they say 500 HU, but when you go inside, it's a solid stone. It's not a black stone. It looks like a uric acid stone, but it's a packed uric acid stone. So it's also hard to do lithotripsy. So well, basically, what I tell the patients is, it's never 100%, but we will try to do our best. Fortunately, most of the stones are that we find in our practice is not super big. There are some patients, pero for these patients who have very big stones, I already say that there's a chance that we might do a 2-stage procedure. And also, sir, can I comment on the regional anesthesia? I just have a question also. Because for regional anesthesia, don't you have to do ventilation? And ventilation is at a higher risk for creating aerosols during the procedure. The problem with GA is the intubation part. That's why uh, it is recommended that you do it in a negative pressure room. So after the intubation, the viral particles get sucked out. After that, it's already a closed system. But during regional anesthesia, there are times where you will need to oxygenate the patient. And during that time, all of the staff will be inside the operating room. I'm not sure. I don't know what the protocol is for that. That's why I'm asking.
Well, yes, when we did the regional before, auto cannula lang yung patient kasi naka-supine man kami. So, hindi na kailangan mag-ventilate like for a mask or ano. Ang only problem would be pag nagkaroon ka ng yung bigla mong kailangan i-intubate yung patient, nagkaroon ng problema
Spinal.
yun sa mga ganon.
JM, yes, ka.
Yes, sir.
I'm sorry for being late, no? Meron ako intraoperative emergency. But anyway, regarding sa regional spinal, in Bicol, you are from Bicol, because I was talking with Dr. C a few months ago that they have been doing with spinal. There is this anesthesiologist who does it with them, prone. And he showed me a picture na in the process na nagpi-PCNL, nakangiti pa yung pasyente. You are from Naga, right?
Yes, sir. I've heard about this from my father, pero I don't know if there are any brave anesthesiologists who are willing to do that here in Manila.
Okay, okay. Kasi that anesthesiologist, they have been doing it since he arrived. So that would be around more than 20 years doing spinal, even on pelvolithotomy, and this time even on a prone PCNL spinal. Tapos may picture pinakita, nakangiti pa yung pasyente kumakaway sa'yo habang pini-PCNL.
Yes, sir.
Prone.
My father has been telling me that he
Yes.
does most of his flank surgeries under spinal anesthesia.
Okay,
And
yeah.
I,
I think depends na lang
I
sa
have yet to see
threshold
that.
Yeah, depends sa threshold the anesthesiologist.
Yes, sir.
Yung mga old anesthesiologists, they do that. They're brave to do that.
But I guess
That's
it
just
can
my
be done,
input
sir.
there.
I guess it
Yeah,
can
it can
be
be
done.
done.
But
But
the problem is, if you encounter a problem, it will be difficult to intubate.
that was what I asked them. But so far, wala naman daw silang problem. No? I don't know.
Okay, so
Dr. Greg,
can we,
Dr. Greg, tumataas yung kamay.
JM,
Yes, sir.
with regards to have you, because what I usually do, if especially if yung mga complete staghorn, prolong yung procedure, medyo marami-rami na yung ginamit mo na irrigating fluid. My anesthesiologist usually tells me nga, increasing na yung ventilation, perfusion pressure natin, and it's time to stop. Can we safely use that as a parameter na you better come back some other day pag hindi mo naubos yung stone? Because I reckon it's usually in that 20 to 28, pero kung maabot na yan ng mga 30 na yung ventilation pressure nila, then the anesthesiologist would usually be kind of scared or worried.
Thank you for that question, sir. Honestly, sir, I don't have I have no experience with the anesthesiologist telling me about the ventilation pressure. I have not also seen any studies correlating the PCNL with the ventilation, the status of the patient after the with the change in the ventilation pressure. So I really don't have any idea about that, sir. But
Okay.
what we do to minimize the absorption of the fluid is to give furosemide. I think that's common practice naman, sir, for everybody. We give furosemide. Ako, sir, after every 30 minutes, sir, I give furosemide 40. My limit is 120 or 160.
okay, and last, can we get the reaction from Dr. Lu?
Hi, good morning to everyone. Just a comment on the regional anesthesia that is used during supine PCNL. I've heard, I've watched a webinar also in one of the anesthesia webinar, wherein it is also very important to note the level of oxygenation in a patient. So as much as possible, you must decrease the oxygen flow to the minimum so that it can minimize aerosolation of the said medium. And as well as I have a question to JM. What are your thoughts on performing PCNL right now? Have you performed any PCNL case right now? And how do you conduct it? What are the safety measures that you need to perform prior to doing it? And during the operation, what safety measures do you do?
Nice chicks. Well, during this time I haven't done a PCNL yet, but I have a scheduled or on Monday. So as precaution, of course, I did a RT-PCR swab. It is best to do the RT-PCR swab depending on the turnaround time of the laboratory. In my case, 72 hours was the turnaround time of the laboratory. So I need to have it. I had the patient tested last Wednesday. Today mo kuha yung resulta. So I'll see if so that's the first step. uh, I think it will be safe for everybody because right now we don't know who's infected and who's not. Okay? As an adjunct, if you are thinking that the patient is positive or has contacts with a COVID positive patient, you may do a chest CT scan. Okay? It can be used as an adjunct because it catches some of the false negatives of the RT-PCR. Okay, in terms of the operation itself, the what we can do is when the when
Guys,
during the intubation phase, everybody should be out except for the anesthesiologist and the uh, the anesthesiologist and the assistant. Okay, uh, keep the sir don't do really hard cases. Just do small stones first so that the operating time will be short. For standard PCNL, it is important to keep the drape, use the proper drapes, disposable drapes, and the drapes that have, ano tawag mo doon? Yung may imbudo. So that the contamination of the whole OR room may be minimized. Of course, proper PPEs, proper donning and doffing. I usually, for the other procedures that I have done, even minor procedures, I still don a level 4 PPE.
my question to JM.
Yes, sir.
Okay. I'm sorry kasi I only caught the early part of your lecture. No? Is there evidence that the virus really thrives in the urine, JM?
Well, they have not found live viral particles, but they have found nucleic acid on RT-PCR, which may be one route of viral shedding. Okay? But unlike the feces na merong live virus, you can transmit it talaga. So up to now, there's really no proof that the urine can transmit the virus.
Yeah, yeah. And second question, I don't know if you have mentioned this already. In this time of COVID, the faster the surgery is really advised. Shorter time for the surgery. So if you have let's say, a pelvolithiasis, don't you think you would rather go for a standard rather than a mini at this particular time so that you will be able to evacuate the stone completely at a faster rate?
Well, also, sir, I guess it depends on the expertise and what you're more comfortable with. Like me, sir, I'm already comfortable with the mini PCNL, and usually the operating times are almost the same because the Chinese system, you don't need to change instruments when evacuating the stones. So this kind of makes the surgery a bit faster. But for if it were the normal mini PCNL without the suction irrigating system, definitely I would agree that the standard is faster.
Okay, thank you. Thank you.
Yeah.
Yes, Chief.
Okay, Slot.
Yes. Would you suggest preoperatively to ask for a IDS or a pulmo clearance prior to surgery for all your patients? Because
Well, it was
some hospitals here are requiring, or they're mandatory asking all patients to do IDS or pulmo clearance prior to the surgery.
well during this time. I also think that it would be best. It would be best to seek help from our friends in the other subspecialties, especially for infectious disease, because they are the people who are most up to date with the current situation and the current standards of practice.
Hello, GM.
Yes, Doc Mark.
Hi. I have a question. Even if any other procedure, or even if minor procedure, no, with regards to the accuracy of our physical exam history taking, as well as possible eliciting information regarding kanang history of exposure ba kay most of the time, patients will lie or they will just dismiss kanang possible information that might kanang put them to rest nga meron sila exposure, no? Kasi kadalasan talaga naglilihim or they will just not divulge the information, no? Pwede ba kaya any idea or I will address also this to everybody is regarding performing a rapid test, no, prior to doing the procedure, no, any urologic procedure in this era of pandemic, no, rapid test. Any comment on that?
Sir, the rapid test will turn out positive usually during if the patient already has symptoms or after, that's when the IgG and the IgM becomes positive, and the IgG will remain after the patient becomes convalescent. I don't know about I guess it may be done because it can also screen for asymptomatic patients. For a certain subset of patients, it can be done. But the RT-PCR can detect the virus earlier, definitely earlier. The RT-PCR turns out positive a few days before the IgG or the rapid testing becomes positive, which makes it safe for everybody.
Yes. Kasi dito kasi in our practice here in Bukidnon, I don't know with the other areas, no, we don't have, although in Bukidnon we have 2 centers doing PCR. So here in Bukidnon we have a rapid test kit, no. Actually marami na, even if for you yourself you can order it online or saan or any distributor, no, to have the rapid test kit. Kaya lang kung pwede ba yun as alternative. Meron naman iba dito, when this say patient needs to be scheduled, they try to wait 2 weeks, no? To a certain, maybe during this time, hindi magiging symptomatic yung patients to be safe, no? Kasi wala talagang mahirap mag-RT-PCR dito if you're not symptomatic or hindi ka, I don't know if you can, even if in Cagayan or in Davao, I don't know if they will allow you to do RT-PCR for patients na to undergo surgery, no? Siguro they will prioritize those symptomatic patients and those highly vulnerable patients. Yun lang ang tanong ko. May iba dito, admit, wait for 2 weeks. Pag hindi naging symptomatic, walang ubo, okay, we'll go ahead with procedure. Okay, yun lang. Thank you.
Okay, for the interest of time, we'll have the last 2 questions.
JM?
Yes, sir.
Sa mga areas na wala kaming capability for RT-PCR, do you think it's right na sa informed consent ng mga pasyente, isama na rin namin na, for example, they are asymptomatic or incubating the virus, tapos they should be informed na possibly mas higher yung morbidity nila post-op-wise if they have this virus while having the surgery. Kasi we don't have any RT-PCR for elective cases.
Yes, sir,
Ginagawa
I
namin
think
sa Manila, is it part of the informed consent?
part of the informed consent, sir, in Manila, because all elective cases here are required to have RT-PCR already, at least in most big centers, okay? And part of the consent already includes that you might contract the COVID virus while in the hospital.
Mm-hmm. Okay.
Pero sir, I think it's a very good idea. I think the protocol should be tailored to each locality, sir, because hindi naman pare-parehas yung sitwasyon ng bawat locality.
That's true.
Can I add lang, sir? Dr. Espino. Dr. Greg, that's why
Yes.
there's a need talaga of IDS for now. For now. The value
Okay.
of IDS because they will be the one to clear the patient Sila yung specialty, yun ang specialty nila to clear the patient for any other infection. So at this time, it's mandatory that all cases should be cleared. Probably the discretion kung kailangan ng chest CT scan, X-ray, CBC, whatever. So it's their discretion na kung to screen the patient for possible COVID. Of course, yung sinabi ni JM na RT-PCR, very ideal yun. Kaya lang, hindi niya lahat ng locality meron nun. That's all.
Yeah, and to add to that, I think sa Davao, all hospitals, that is how we practice. Nobody gets admitted or undergoes surgery without IDS clearance. And ang sa akin naman kagandahan doon, it lessens the burden sa surgeon, no, to screen. Para bang feeling mo, okay, safe ng patient kasi na-clear ng IDS. Yun din yung isang part doon eh.
Sir, iba kasi ang situation ng Davao sa Manila. Sa Manila kasi maraming centers ang COVID. Ang sa Davao, we isolated only one hospital as a COVID center, which is SPMC. Yun ang kinaganda lang ng Davao kasi na-control na-isolate lahat ng COVID sa isang hospital lang. Whereas sa Manila, they are accepting COVID in any institution or any maraming hospital. That's all. Thanks.
Kaya ang mga private hospitals sa Davao are considered parang clean hospitals as of the moment, no? We will only be accepting pag may spill. Yeah.
Yes, tama yun, sir. Okay, agree, sir.
Okay, so let's have the last question before we close the session. Yes, I think Dr. Escobidal is raising his.
Congratulations, Dr. Ursua.
Thank you, sir.
Well lectured. I hope we can have Prexy Rod Hipol. We can have the recordings of this meeting. Just send the link. Okay, thank you very much.
Alam ko na to kung bakit gusto mo makakuha yung recordings.
Kasi late ako.
So talaga,
inviting everyone tomorrow for a live forum. Kindly send the link I have sent to our chat group to your non-doctor friends. Okay. Thank you very much.
Dr. Toto, nakahiga ka ba?
May mga gumagawa na rin yan dati during our DRE month. But this time, the platform is different. Zoom and simultaneous broadcast with the radio station. And at the same time, going on FB Live. I hope you can join me tomorrow 3:30 p.m. Thank you very much.
Okay, that's well noted. Okay, I'd like to thank JM for the 2 lectures, and we hope we learned a lot from those 2 lectures. And I now turn over to our president, Dr. Hipol.
Thank you for everybody in attending the second webinar. And I think we have 4 past PUA presidents attending. And it's also nice to see the new faces kasi nagbago na, no? Ibang mahaba na ang balbas at saka ang buhok, no? But nevertheless, while we are here having our quarantine, next week we'll be going to have e-ratification of our constitution. And it will be moderated by no less than Dr. Raul Andutan. And I've already sent a copy of the constitution through our Viben. Hopefully, at least you can browse on it at least once before next Saturday, but at least facilitated yung flow. And then on the last Saturday of May, we'll be having another 3rd webinar, and the topic will be just posted to follow. And siningit na ni Toto, our e-lay fora or forum, and it will be a combination of e-platform and also mass media. So hopefully mas maganda yung reach and just spread the news. And maybe from
Rexy Rod, if
Yes.
I may interrupt. Kasi ang ang pwedeng gawin ng POI Mindanao Chapter, national coverage. Ito yung gagawin mo na pwede mong i-forward sa kanila. I hope maging okay yung pilot activity natin. Thank you.
Okay, okay.